Hello, I'm Junheng Lee from Samsung Medical Center, Seoul, Korea. Today's topic is diagnostic and therapeutic endoscopy for early gastric cancer. This slide shows the Korea cancer statistics in 2014. As you can see, gastric cancer is the most common malignant disease in males and number 4 in females. The incidence is still high, but 2/3 of all gastric cancers are curatively treated. The incidence of gastric cancer in Korea is slowly decreasing, but the mortality rate is rapidly decreasing. In 2013, the mortality incidence ratio was 0.31 in Korea. This picture shows the estimated gastric cancer incidence and mortality in 2012. Korea and Mongolia is number 1 and 2 in the incidence of gastric cancer. The survival rate is highest in Korea, followed by Japan. It is probably due to early detection by screening program and high surgical and endoscopic techniques. First topic today is endoscopic diagnosis of early gastric cancer. Early gastric cancer is defined as a gastric cancer limited in the mucosa or submucosal layer, regardless of lymph node metastasis. It is classified as protruded, superficial, and excavated types. The superficial type is further divided into flat, elevated tray, just flat, to B, and slightly depressed to C type. The most common type is EGC2C. As you can see in the cartoon, EGC can have a lot of fold abnormalities and border changes. Typical abnormal folds in EGC includes abrupt tapering, abrupt interruption, clubbing, and fusion. There are a few important blind areas in the stomach. In order to observe the whole stomach without blind area, initial endoscopy training is very important. Left side is a Kogan simulator video clip, and you can compare with a real patient endoscopy using Pentax I10C gastroscope. As you can see, it is quite similar. Beginners can learn a lot of technical tips with gastroscopy box simulator training. I strongly recommend it. Due to time limitation, I will move into case discussions. The first case is EGC2A. A 79-year-old male patient was referred for the further evaluation of gastric neoplastic lesion detected in the screening endoscopy. It was a 2 cm sized, pale, slightly elevated lesion in the greater curvature side of the gastric antrum. Biopsy was not done in the screening center, but the patient has a history of adenoma. He did not receive any treatment for gastric adenoma with low-grade dysplasia for 2 years. We performed endoscopy and the biopsy was atypical gland with high-grade dysplasia and focal carcinomatous transformation. So, endoscopic submucosal dissection was done with the Pentax I-10C gastroscope, and the final pathology was moderately differentiated tubular adenocarcinoma, 20 mm, limited in the mucosal layer. The second case is EGC2B. Can you see the border of this superficial lesion? Do you agree with me? Anyway, subtotal gastrectomy was done, and the size was more than 5 cm, but it was limited in the muscularis mucosa. The next case is a very young patient. A 19-year-old girl student visited a local clinic due to an episode of melena. In the initial endoscopy, a flat elevated lesion was found in the esophagogastric junction. The biopsy was reported as at least high-grade dysplasia. Immediate follow-up endoscopy was done at the same clinic, and the biopsy result was tubular adenocarcinoma, well differentiated. After referral to Samsung Medical Center, we repeated endoscopy again, and the biopsy result was moderated differentiated adenocarcinoma. What would you recommend as a treatment? Total gastrectomy, or proximal gastrectomy, or endoscopic treatment? My option was ESD. Endoscopic submucosal dissection was done by Professor Yang Won Min of our institution. Standard procedures were followed. The final pathology was 16 mm sized EGC2A, limited in the mucosal layer. In the follow-up endoscopy, ESD ulcer was completely healed. The other gastric mucosa was completely normal, and there was no evidence of Helicobacter pylori infection in Jimja staining and serology. My next topic is ESD for EGC. There are two types of indications. Absolute indication means differentiated type mucosal cancer without ulcer and not bigger than 2 cm. Expanded indication include differentiated type early gastric cancer bigger than 2 cm and selected cases of undifferentiated type early gastric cancers. This is a real-world statistics. Among 355 early gastric cancers initially treated by ESD, 120 cases belong to the beyond absolute indication group. Some of them require surgery. 10% of patients in the absolute indication group were initially treated by surgery, and you can see the reason in the box at the right-hand side corner. Suspicious lymphadenopathy is the most common reason for surgery. Korean practice guideline for gastric cancer was just released. The first statement is about absolute indication. Endoscopic resection is recommended for well or moderately differentiated tubular or papillary early gastric cancers meeting the following endoscopic findings. endoscopically estimated tumor size less than 2 cm, mucosal cancer, no ulcer in the tumor. Let's talk about expanded indications. Do you think total gastrectomy was really necessary for a 45-year-old lady with just 1 cm signal ring cell carcinoma? In my opinion, it was too much. Less invasive options should be considered. What would you recommend for a 40-year-old woman with a small, flat signal ring cell carcinoma? I performed ESD and the final pathology was a signal ring cell carcinoma, 10 mm, limited in the lamina propria layer, clear resection margins, and no lymphatic invasion. ESD for expanded indication cases can be selectively performed in the individual cases. Flat, small signal ring cell carcinomas are frequently treated by ESD in Korea. Outcome of endoscopic treatment of early gastric cancer with differentiated type histology is well established. We have ITT analysis such as comparison with surgery using propensity score matching. We also have PP analysis such as long-term follow-up data after curative resection or non-curative resection. At my institution, we performed a propensity score matching analysis between the two groups, endoscopic resection or surgery for differentiated type early gastric cancers. The overall survival was almost the same in the two groups. Because of the metachronous recurrences, disease-free survival and recurrence-free survival is better in the surgery group. However, there was no difference in the disease-specific survival. Next evidence is the PP analysis. It's a single-arm long-term follow-up data for curatively resected differentiated type early gastric cancers. Excluding metachronous recurrences, we experienced only one case of local recurrence and 2 cases of extragastric recurrences. This is the overall survival. There was no statistical difference between absolute indication and expanded indication. These are the pictures of the 2 extragastric recurrences in our series. The top case belonged to the absolute indication group, and the lower case belonged to the expanded indication group. This is another PP analysis for non-curatively resected differentiated type EGCs. In cases with risk of lymph node metastasis, 70% were operated and 30% were observed without surgery. In the surgery group, 11 had lymph node metastasis, which means 5.7%. In terms of the overall survival, additional surgery was related with better outcome. Survival benefit of additional surgery after non-curative resection was shown in a propensity matched study by Dr. at Korea National Cancer Center. As you can see at the right-hand side picture, the overall mortality of observation group was higher than that of the matched initial standard surgery patient. Maybe we are doing too much surgery after ESD. Do you think surgery is necessary for mucosal cancer with lymphovascular invasion? As you can see in the red box, in lymphovascular invasion positive patient within the traditional absolute indication group, there was no lymph node metastasis in surgery. Careful observation without additional surgery can be an option for this group of patients. Next topic is ESD for EGC with Pentax/M knife. /M knife is a new multifunctional ESD knife from Pentax company. It has a needle-type tip with hooking mechanism. At the distal end of the knife, there is a metal plate which is useful for bleeding control even in retracted position. The length of the ESD needle is 2 mm in extended position and 0.5 mm in retracted position. In my recent experience with the /M knife, I found 3 advantages. First, the hooking mechanism is very useful for the submucosal dissection group. When a lesion is located at difficult location, the approach is not easy. I usually used the dual knife and IT2 knife for a patient. But with /M knife, I can do the procedure without using the IT2 knife. Second, the metal plate at the end of the /M knife provide enough contact area for the bleeding control during the ESD procedure. Finally, the procedure time is much saved due to the water jet function. In a recent study from Japan, ESD using /M knife appeared to reduce the use of hemostatic forceps during the gastric ESD without increasing the adverse effect. It can reduce the total cost of the treatment. This is a typical case of early gastric cancer treated by endoscopic submucosal dissection with Pentax/M knife. From now on, I'd like to show you a video clip of endoscopic treatment of an EGC. A 21-year-old male was referred for the endoscopic treatment of early gastric cancer. The initial biopsy was moderately differentiated tubular adenocarcinoma. These are settings for my standard ESD. Pentax system, I10C gastroscope, 5-Medix injector, /M knife, and so on. The procedure was done as usual. The lesion is located on the anterior greater curvature side of the gastric antrum. It was a slightly depressed lesion. I scan image. After spraying indigo carmine, marking with /M knife, submucosal dissection is done starting from circumferential cutting. submucosal dissection step. Final images. Now the video. Anterior aspect of the antrum, there is a depressed lesion. Pentax I10C gastroscope close-up image is so good. This is image-enhanced endoscopy named iScan. I usually use indigo carmine to determine the lateral margin of the tumor. Now I try marking with splash M knife in retracted position. Marking is done like this. I usually start cutting from the distal margin. Submucosal injection is done like this. Initial circumferential cutting is done like this. This is push technique. Okay, distal half circumferential cutting is done. Additional submucosal injection. Proximal part is cut like this. So submucosal dissection is done like this. You can use the hooking mechanism. When there is bleeding, you can immediately control the bleeding like this. Some more submucosal dissection with hooking function. Traction is possible due to the hook. Okay, almost done. You can inject some more water through splash M knife. No need for submucosal injection using a needle. Okay, this is the final cutting. After the final cutting, hemostasis is done using the same splash M knife. You don't need to use hemostatic forceps. Almost done. Final pathology was 11 mm sized, moderately differentiated tubular adenocarcinoma, limited in muscularis mucosa without lymphovascular invasion, curative resection. The tumor was limited in the mucosa layer above the muscularis mucosa. Closed-up image of moderately differentiated tubular adenocarcinoma. Ladies and gentlemen, this is my last slide. The advantages of Pentax Imagina I10C gastroscope and Splash M knife for ESD include good close-up view, excellent angulation, 3.2 working channel, multifunctional M-knife with bleeding control and hooking mechanism. Thank you for your attention.